Our center has a lot of experience with this technology. We've been using the technology now for about 2 years, and we've really tried to apply it across many different points of care, and some we've found incredible success with, some not so much. And I think we're now starting to figure out how to integrate it into our system. So I want to tell you a little bit more about our system, and then also tell you about what we thought worked and what we thought didn't. And like many of the speakers, I do think there's a role for this to be synergistic with other technologies we use. So to tell you a little bit about where Moses Cone is, or Cone Health, you can see Duke here, UNC, Wake Forest, and right in the middle of all these powerhouses is Moses Cone Hospital. Most people haven't heard of Moses Cone. This is our hospital. Moses Cone Hospital is a tertiary care center. It's a teaching hospital, about 520 beds. It's a level 2 trauma center, and our cardiovascular section has really been very strong in the interventional front. And over the past 5 or 6 years, we've had a real push to develop our heart failure program. We've developed a non-transplant VAD program with about 60 implants to date over the past 4 or 5 years. So really an emphasis on early adoption of technology and trying to have patients be able to get their care at our center. As part of our center, though, the other thing, we have 6 hospitals in our center. And we also have a very large at-risk ACO. So we have almost a 90,000, 100,000 patient ACO now. It's about the 11th largest in the country. Now we not only become responsible for our hospital, but we become responsible for the hospitals around us in our network. Many of these hospitals have general cardiologists, but no heart failure doctors. Some of the hospitals don't even have cardiologists. And they look to us to say, how can you help us? They've asked us to come down, they've asked us to help with clinics down there, and with only 2 advanced heart failure providers at our center, we're a little bit strapped to help the partners, but their numbers affect our numbers. It's part of the ACO. So we went looking for technology, we went trying to figure out how do we make more of us without making more of us. Here's our network a little bit. As you can see, overarching is the Triad Healthcare Network, 90,000 patients. You'll see Cone Health here. On the far right, you see Alamance Health, which is another hospital, which is part of our network. And then one of our satellite hospitals, or sister hospitals, Randolph Health, which isn't directly part of our hospital, but about 35 miles south and a big part of our ACO, and also our skilled nursing facilities. And we see this, once again, as a continuum of care in our heart failure program. The first thing we did when we got a vest, we brought the vest down to clinic, in our advanced heart failure clinic. We see 35 patients a day there between the nurse practitioner and the physician, and we got comfortable with the vest. We tested about 200 to 300 patients consecutively just to feel how does this vest work. Like Nir spoke a little bit about it. How does it feel? What do the numbers look like? How does it correlate with symptoms? And the first thing we found that 42% of patients walking into our clinic had an elevated vest reading, so over 35%. So 42%, and 25% of those patients had readings over 40. So not just a little bit wet, but considerably wet. Sean referred to some of the data looking at post-discharge. And if you look some of the HERE registry data, where about 50% of patients get discharged from the hospital who've either gained weight or just lost very little weight. So we thought once we got comfortable with the vest and the technology, we took it to the ward. And we did a trial we called the Best Discharge trial. And what you can see here, this is a single center randomized trial, about 110 patients. And these patients came with a decompensated heart failure. We have about 125 admissions per month at our hospital for heart failure. So we were able to enroll pretty quickly. We did this over about a 6-month period. The patients got screened, and then they got randomized. They got randomized to a treatment arm or a control arm. And then they were allowed to be taken care of. Now, they're either on the hospice service, they were general cardiology service, or they were on the teaching service, either family medicine or internal medicine teaching service. If they were on the heart failure service already, they were disqualified. So people got enrolled. There was 60 patients in the treatment arm, 48 patients in the control arm. And then we broke them down within each group, dry or wet. So the doctors called, they said, listen, patient so-and-so is ready to go home. If they were in the control arm, they just went, we measured their REDS reading and we sent them home. It went to the cloud, it was blinded, nobody knew about it. In the treatment arm, the patient got measured and then the number came up on the screen and we were notified. If it was under 39, they got to go home. If it was over 39, they jumped up and down in their room and said, I'm going home anyway. And then the heart failure doctor had to walk into the room and tell them, wait a minute, you're not going home just yet. So if you look at that patient in the treatment arm, you see 60 patients were enrolled, and almost a third of them, 18 patients, had a REDS reading of greater than 39. So we called this treatment wet. on the control arm, you see it was sort of similar. There was, you can see, and there was also 17 patients out of 48. So about a third of the patients in the control arm were also wet, and those were discharged as planned. For the intervention wet arm, what happened? You got a heart failure consult. Heart failure physician came, saw the patient, and then we took over therapy for that patient's heart failure. If you see what we had, then what we did. So here's sort of our primary endpoint was to look at the level of congestion remaining in patients prior to discharge. So these were patients who a doctor saw them and said, "You are ready to go home today." And what you see, so if you look at all comers, 32% of the patients had a ReDS reading that was greater than 39%. So these are patients, 1/3 of patients had a number that we would feel uncomfortable with seeing in the clinic and say this patient needs further intervention. 12% of patients had this sort of intermediate number between 35 and 39, which was mildly congested, and 56% were adequately decongested. So you have 44% of the patients that we measured their lung water before they were leaving the hospital who were thought ready to go home and had still had elevated lung water. So we think there's a big opportunity here. And then what we looked at as a secondary endpoint, is there a benefit of treating those patients further, and can we affect outcomes? So this is a really busy slide, and I apologize. I'll walk you through it. We'll start on the right side here. So as a secondary endpoint, we looked at 30-day readmissions. So if you looked at the treatment arms, so these are the treatment arms with people who had a ReDS reading greater than 39. So if they were in the treatment group, what happened if they were 39? They were seen by the heart failure doctors, their medicines were titrated, and they typically spend an average of 2 more days in the hospital before they could go home. In that group of 18 patients, there was 0 readmissions if we got involved prior to discharge. If you then go down to the control arm, so this is the people who were discharged, the number was blinded, we went back and looked at it. If you looked into that arm, the control wet arm, 17 patients in that arm, in 30 days, 2 of those 17 patients were readmitted for a readmission rate of about 12%. I'll preface that a little bit. We have a lot of programs in place in our hospital. Our baseline readmission rate is about 16%. So our baseline readmission rate is pretty low. We haven't got penalized in 5 years. If you looked at all comers, all ReDS were greater than, so these are the dry patients. If you looked at everybody who was decongested adequately before discharge, only 1 out of 73 patients got readmitted. So if you were decongested well at the time of discharge, you were dry when they said you were dry, only 1% of those patients got readmitted. So there seems to be some benefit of making sure these patients are decongested at the time of discharge. You know, there's been a lot of data before looking at like how much weight they gain and stuff. We actually measured their lung water prior to discharge and tried to prove this point. Granted, the numbers are small. We're underpowered for a lot of these things, but we still think the 30-day data is pretty powerful. If you look at the 90-day data, like, it's hard to believe that, look, what your lung volume is now, will it really affect what happens at 90 days? We didn't expect it to really affect much. And if you look at the patients, all ReDS, so look at the middle row, all ReDS, so everybody less than 39%. So these were people who were adequately diuresed at the time of discharge. That group had a readmission rate of about 15%. And that's what our readmission rate is for sort of all comers in our population. But interesting, if you were in the control arm and your ReDS vest was greater than 39 at the time of discharge, that patient population had a 24% readmission rate. And I think that tells you 2 things. One is their volume overloaded, and 2 is it's really hard to tell in some patients, like Scott pointed out, are these patients volume overloaded or not? And that's a high-risk population. If you look in the ReDS arm, so look in the ReDS arm. So this is the arm where there's the treatment arm, patients greater than 39%. And this is where the heart failure team got involved. At 90 days, that readmission rate was still pretty low, 6%. But what happened here is those patients got referred to the heart failure clinic. So at discharge, somebody couldn't assess their volume status right. So he said, this marks you for a higher risk patient, and you need to be enrolled in the heart failure clinic so they can follow you more closely. Now, if you turn your attention to the big graph on the other side, you can see this is a little bit difficult, but the white bars are 90-day readmission rates. So just look at the 90-day readmission rates. If you look at there was 24% in the control wet arm got readmitted, 24% in 90 days. In the treatment arm, where patients were referred to the heart, were decongested at discharge and referred to the heart failure clinic, it was down to 6%. And I will say this is probably a combination of decongestion and adequate triage of these patients to the right resources. And overall, it's a 75% decrease in readmission, in 90-day readmissions in this program, in a hospital that's already averaging around 16% of readmissions, 16% 30-day readmission rate. So I think it really helps not only getting people dry, but I think it helps identify that person that we continually underestimate their fluid. So here's what sort of the granular data looks like. Average length of stay on these patients was extended by 2 days when the heart failure team got involved. As you talk to our administrators, they'll make that 20 days. They say I keep them 20 days too long, but it was only 2 days. They lost 5.7 pounds. The real interesting thing about this is the mean REDS decrease was 8%. So with 2 days of diuresis, we saw the REDS value go down about 8%. So unlike BNP or other things where you can't really track what you're doing, if patients are, you can't tell with weight, you can't tell with other things, but we were actually able to track, are we having an effect on this patient or not? It is very responsive to therapy, and that's one of the things we like best about it, is that the responsiveness of therapy is immediately measurable within 24 hours. We had one episode of worsening renal function, creatinine bumped to 0.5 grams per deciliter. We held the diuretics. We didn't call nephrology, and they got better the next day. It was interesting, within the trial, there was one person who had a super high REDS reading, over 55%, and didn't look wet on exam. And it's sort of an aside, and super high REDS reading, and everybody was giving him diuretics. He wasn't responding. We came by and we saw this REDS reading that's like, it's really out of the norm for us. Went back and looked at all his imaging studies, turned out to have acute pneumonitis. And so we started to learn, when we see these clinical pictures outside of what we really think is really, really pulmonary edema. If you go back, we got a SED rate, it was 115. We really learned to use the REDS sort of out of the box a little bit, that these super high numbers might also be telling us something. So in conclusion, 1/3 of decompensated heart failure patients are discharged with significant congestion. I would say 50% of patients are discharged with at least mild to moderate congestion. The patients, there was what seems to be a significant decrease in readmission rates, and it was a safe therapy. Perhaps the project we're most proud about is, from the initial slide, we had a hospital that's about 30 miles south of us, and they're a hospital that struggled with heart failure readmissions. They have 4 cardiologists there. They're very busy, but none of them have really a great interest in taking care of heart failure patients. They have a very active home health program that's run by 3 nurses within their hospital. And they reached out to us and said, we need someone to help us with this. Can you help us with it? And what they meant by help is, can you see our patients? And we said, we love you guys, but we're not coming down there. So what we did is we bought a vest for the nurses. We bought a vest for the nurses. We trained the nurses, and we said, here's what we want you to do. When patients go home from the hospital, we want you to run out to their house, measure them, and figure out what their number is. If their number is above 35%, we'll give you a diuretic protocol. Our pharmacy team created a diuretic protocol. We'll give you a diuretic protocol to get them into their normal range. Once they get into the normal range, then it's going to go to ad hoc. So the patient can call, and whenever they call, we'll run back out there with a vest. But we're not going to keep running out there unless they call. Get them to the normal range, and then we'll use a PRN protocol. And then there was, we would check electrolytes and those things. And this was a pretty amazing story for us. So when they started, their readmission rate was 25%. They had gotten penalized every single year. Medicare had a penalty and had another one on the way. And this is a rural North Carolina hospital was really struggling. So we had enrolled 105 patients into the trial. 52% of the patients had elevated REDS readings on arrival when they got home. So almost similar to what our data showed. These people were being discharged wet. And it took about 2.5 visits to get these people into the dry range, into their green zone. What happened within that patient population, we reduced the readmission rate within that patient population to 3%. And we never saw one of those patients in our clinic. This was all done remotely with 3 home health nurses. Their readmission rate within the first 6 months went from 25% to 15% and stuck there. They got $800,000 back. They didn't even offer to take us out to dinner. We're still waiting for the invite. If you know them, tell them we're here. We're ready to go. Scott's going to come with me. And so really a very dramatic thing. And, you know, the 3 home health nurses now are the biggest proponents of this technology I've ever seen. They have now become empowered. They would go out and they would see these patients and say, look, we see them, we know they need help, we don't know what to do. And now they call and say, hey, listen, Dan, I got this patient, they got a little bit of edema, their weight's up a pound, but they have a ReDS reading of 40. Now I know what to do. Now I can direct them and give them advice and actually help them manage the patient from afar instead of saying, why don't you just send them to my clinic tomorrow, I can't figure this out. So the words I use for this is we've created now a heart failure army. We have all these little armies out in different towns around us that are doing the work for us and sort of reporting back to headquarters, and we give them the protocols to follow. So it's been a great protocol there. You can see some of the conclusions about this. So it's really been successful in reducing 30-day heart failure readmissions. It's been safe, and the best thing about it is it hasn't taken any more of our advanced heart failure resources to pull this off. A couple more slides, and I know it's time to wrap up, but I just want to go through 1 or 2 more slides to talk to you about how else we're thinking about using this device. So if you come, this is Alamance Regional, this is another one of our system ERs. The numbers are very similar for our ER. We've done sort of the same thing. If you have heart failure and you come to our ER and say, I'm short of breath, what's the chance you're going to get admitted? Any idea? Like 105%, right? You're going to get admitted, go home, you can get admitted again, right? So it's in our ER, it's between 85 and 90%. All you have to do is say heart failure to an ER doc, and they're already calling the cardiology team to come admit them. So we thought, you know, if we can lock the front door a little bit, can we really block the final common pathway of readmissions? So what we did is we took the vest down to the ER, and we said, let's just measure a few patients. How about that? So what we did, and you can see we gave them this guideline. If ReDS is less than 35, that's low risk. You just send them home or look for something else. Then 36 to 39, if they're in that mid-range, give them a dose of Lasix, send them home, and we'll see them tomorrow to try to get them out of the ER. And then if they're really high, greater than 40%, you probably should admit that patient. They really didn't listen to us. The first patient they got was 53. They sent him home. He came back 2 hours later and almost got intubated. So we said, you know, we told you how to use this thing. We don't want to talk about this again. But if you look at the data, and you look at our data, look at the numbers a little bit. So with a ReDS reading of less, these are patients presenting to the emergency department saying, I am short of breath. I have heart failure and I am short of breath. 1/3 of patients are less than 35%. 26% are 36 to 39%. So 60% of patients that come into our hospital ER probably don't need to be admitted for heart failure. And then greater than 40%, there was 41%. So about 40% really need to be there, and we need to see those patients. So there's a big opportunity there, right? If we can take that admission rate from 90% to 70%, you know, that's a huge, huge win for us because that locks the front door. And it also gets patients to be familiar with our heart failure clinic. So this is really our next frontier, and hopefully next year when we come back here, we'll have this data really built out for you to show how it worked. Finally, before I let you go back and enjoy downtown Nashville, I want to talk about one patient. This is a patient that happened just a couple of weeks ago with our home health nurse, and I just thought it was fantastic. This is a woman, she's 72. She is a North Carolina medium, so BMI is about 40. But she had an EF of 54%. She had hypertension. She was discharged from another hospital. She was in Pinehurst, actually, and she came back to the Randolph community where she lived. And our home health nurses picked her up, that she wanted to be involved in the program, so they picked her up. So they went to her house about just a little under a week after she got home. And her home diuretic regimen at the time was torsemide 20 BID, metolazone 2.5 every 3 days, spironolactone 25, and potassium 40 daily. And so they went out to the house. The ReDS reading was 40. So by now, everybody's thinking, okay, we're going to do something about that, right? So the diuretic protocol says double your loop diuretic. So they doubled the loop diuretic to 40 BID, and they got blood work the next day, and all she could tell me was the sodium's 120. So what do we do now if the sodium's 120, the sodium's 121? So we stopped the metolazone, we held her torsemide, we thought we'll be really smart, we'll order tolvaptan, right? We'll really fix this. Well, rural North Carolina doesn't have tolvaptan anywhere close. And our pharmacist refused to drive to the patient's house with a $250 pill. So we couldn't get tolvaptan, so we'd held the torsemide, and now the REDS the next day is 44%, right? So we're like, okay, what do we do now? So we called no, we didn't call nephrology. We restarted the torsemide at 40 BID, so double the home dose. We dropped the metolazone, kept potassium at 40 a day. And now the next day, the REDS is 41. So you see, we're starting to have an effect. 24 hours later, we're starting to have an effect. We see a change in the REDS. We get an idea of where we are. Weight's stable, sodium's up to 124, potassium's 3.6, still has 2+ edema. And we say, okay, we got a little ways to go, right? We're making progress here. So we increased the torsemide to 60 BID. We increased the potassium to 40 BID. Next day, REDS is 36. So now we're starting to get pretty happy, right? We're starting to get pretty happy. Creatinine bumps from 1.2 to 1.4. We're like, okay, a little bit. Weight down a pound, edema's down a little bit. And so we said, let's just take the torsemide to 60-40 and just park it there. Just leave it there. It seems to be the right thing to do. So 2 days later, the REDS reading is 36%. Sodium's 131, potassium's 5.1, and creatinine is 1.3. We adjusted her potassium. 1 week later, they go out to the house. She's still on 60-40. Sodium's 133. Creatinine's back down to 1.3. And we have our diuretic dose. We have figured out where this diuretic dose needs to be. And so the nurse calls, and she was so excited. She's like, we were going back and forth about this. She said, when we first saw her, she was hunched over with a walker and short of breath. She's been this way. She's had multiple admissions. Now she ambulates freely, smiles constantly, so does her family. When, we talk a little bit about the difference between pressure and fluid, and I think you hear that pressure and fluid wedge and thing. Like Nir, I'm a huge believer in hemodynamics and taking people to the cath lab and figuring it out. But what, a wedge pressure, we all had people on the table with a wedge pressure of 40. Wedge pressure is not what it gets you admitted. Fluid in your lungs is what gets you admitted. If you have fluid in your lungs and we're not measuring it and we're not acting on it, you will not feel well. Many patients I think we know. I think, to ours, we've proved it to ourselves. I think there's a lot of registry and there's a lot of data. People say always people are going home wet. I think we finally proved it to ourselves. 40 to 50% of patients are leaving the hospital too wet. And I think it's okay to go home if you're still volume overloaded, as long as you know that and you continue to work on it as when they get to the clinic. And I think that's, we were talking a little bit earlier today, is maybe that's one of the roles for some of our new medicines. Entresto, and things, you send people home and keep diuresing them as they go. I think REDS is extremely, extremely helpful. Like CardioMEMS, REDS is really helpful in determining the appropriate diuretic regimen. It lets you know how to do it and where to go and can you do it safely. And then once you got them, right? I think a lot of us who have used CardioMEMS in the past, once you actually get them dialed in, they're pretty good for a while, right? They do the right thing. And I think it's the same thing with REDS. Once you got them, you got them. Once you've optimized them, got them on the right diuretic regimen, the need for really tight, intensive further treatment really goes down because patients are more aware and you sort of have them on the right regimen. Before they pull me off the stage with a can, I'd just like to thank my team. There's a bunch of members from my team here. Lisa Curran, Daphne Wood, Jackie Brennan, Erica Nicholson are our heart failure team who really do the day-to-day and make this stuff work. I come up here and talk about it, but they do most of the work. So thanks, guys.